Everybody, it's Dr. Becker. Moving on now to chapter 52. This is very similar to how Lainey's presented the women's health chapters. You've listened to these in order. This one is going into the men's health. Chapter 52 is going to cover testosterone, essentially. And then the next chapter covers more about specific to men's health with BPH or erectile dysfunction or those kind of issues. So just like in the last part for women's health, we're going to go through and talk about androgens, how they work physiologically in the body, how they're synthesized, and understand then when we use them for pathologic conditions, then what would we use testosterone for? How do we give it? What kind of side effects and patient education would we need to know? So jumping right into that, a couple facts about androgens. They're hormones that promote the expression of male secondary characteristics, and these hormones are produced by the testes. We as females, if you're a female, do have some produced as well in our ovaries, or they're produced in the adrenal cortex. The main endogenous androgen that we talk about is testosterone. The androgens are noted most for their ability to promote the expression of the male sex characteristics, but they also influence sexuality in females. So androgen, specifically testosterone, is also a player in the female reproductive or sexual characteristics situation, but mainly for the purpose of this, we're addressing men's health. They do, of course, have significant physiologic and pharmacologic effects unrelated to sex or sex characteristics. So to start off with, let's talk about biosynthesis and secretion. So we can make ourselves a new slide for that one, so you have some room if you're taking notes. So testosterone in men is made by the Leydig cells of the testes. The synthesis of testosterone is promoted by two hormones, so very similar to that of females. So in order to synthesize testosterone, you need the anterior pituitary to produce follicle-stimulating hormone and luteinizing hormone. And they refer to these as the interstitial cell-stimulating hormone, so the ICSH. So very similar to that of females, that the FSH and the LH are also necessary to be produced by the anterior pituitary to help regulate and maintain levels of testosterone for the male. Production of testosterone is regulated again by a negative feedback control, very similar to that of females. So you have the rising plasma levels of testosterone will then signal back to the pituitary to suppress the release of the FSH and the LH, and then that is very similar where the feedback will kind of turn itself off. So very similar to that, like of estrogen, testosterone has its own kind of control through a negative feedback system that's in place. There is some of the men's testosterone that is also produced by the adrenal glands, but this kind of androgen activity of the adrenal organ is much less than that of what they produce in their testicles. So the male adrenal androgens have minimal functional significance. So for the purpose of this, we're really just referring to the androgen that's produced in the testes. As we know, testosterone production changes over time. This is very similar, again, also to the estrogen production changes over time. Our peak production occurs around age 17, and then they remain steady till about the age of 30 or 40 for men, and then they start to slowly decline, so that by the time a male reaches 80 years, the testosterone production is only half of what it was in his youth. In females, the pre-androgens, which are the precursors of testosterone, are secreted by the adrenal cortex and the ovaries, and then in the peripheral tissues, it's converted to testosterone. The total amount of testosterone is 10 to 40 times less than the amount of testosterone that's produced in men. Sometimes, though, if you have some kind of pathology of the ovaries or the adrenal cortex, you can, like a carcinoma or just a condition that causes hyperplasia, you can have significant increase in the secretions of testosterone in a female, and that could be enough to produce sterility. And then at menopause, testosterone production does decrease in the female. Okay. But in men, then, biosynthesis and secretion, so we're secreting it mainly within the testes, and that's pretty much the only form that we're talking about. And that, remember, it still has its own negative feedback system as well. So next, how does testosterone work, especially if we give it exogenously? So its mechanism of action. The way that testosterone works on target tissues is specifically mediated on the receptors located within the cell cytoplasm. So after binding of testosterone to its receptor, the hormone receptor complex then has to migrate to the cell nucleus and then acts on the DNA to promote the synthesis and the changes that'll happen. So again, these are slower acting things because they have to bind on the cell receptor and then migrate into the cell to work within the nucleus. So they do not work on the cell surface, is what they're saying here. So in turn, then, once they've gotten into the cell nucleus and they mess with the messenger RNA molecules, then those in turn serve as templates for the production of specific proteins, and that mediates testosterone effects, okay? So it's noted that in some tissues, specifically the prostate, the seminal vesicles, or hair follicles, androgen receptors do not interact with testosterone itself. Rather, they interact with the dihydrotestosterone, which is a metabolite. But in essence, the understanding here is, first of all, it's going to be slow because it has to migrate into the cell nucleus and not just working at the receptor. And then through working on the nucleus, the DNA then affects the RNA molecules, which in turn trigger the production of some of the other specific proteins as well. So next would be pharmacologic effects. And we're talking specifically about testosterone. So first of all, as we know, testosterone is what is needed to initiate puberty transformation in males. So the increased production of the testosterone in the testes will promote the transformations that will signal puberty in males. So it's under the influence of testosterone that the testes begin to enlarge, and the penis and scrotum will then also enlarge. This is also what triggers the development of pubic and axillary hair, and then eventually hair on the trunk, arms, and legs will start to form to be that of a male pattern hair distribution. The testosterone stimulates the growth of bone and the skeletal muscles at that point, which is when a male child into adolescence will have a significant growth spurt. And then you should see a fairly quick weight gain associated with that as well. Testosterone also will then be what is responsible to accelerate the epiphyseal closure, so the growth plates, causing the bone growth to cease within a few years of that. Interesting too, is different from females, is that the testosterone effects during puberty also cause the larynx to enlarge, so thereby deepening the voice and giving us the quote-unquote Adam's apple. Also, during this time, testosterone will cause sebation glands to increase in number, so your skin becomes oily, and oftentimes acne is what will happen when the skin's, those cells get clogged and infected. And then the final pubertal change is beard development. Several years are required for all of these changes to occur. So that's one of the main physiologic effects of having testosterone in males. Second important one then is spermatogenesis. So the androgens are necessary for production of sperm by the seminiferous tubules and for maturation of the sperm as they pass through the epididymis and vas deferens. If you don't have enough androgen production or testosterone production, that is also what can lead to sterility. Under normal conditions in females, testosterone should only really have moderate effects. Among those, though, are necessary. You have to have enough testosterone to have clitoral growth and even maintenance of normal libido. But then when the production of your testosterone becomes excessive, then that's when sterility can occur. So next physiologic effect of testosterone is the anabolic effect, is what they call it. So that's why you would refer to like steroids used to develop bone and muscle growth would be anabolic steroids, right? So testosterone works on our body through the skeletal muscles. This is called the anabolic effect because it results from the binding of the testosterone or androgens to the same type of receptor that mediates androgen actions in other tissues. And so the effects in young males and in females of any age can be dramatic, but in healthy adults, the effects are only modest. The testes of the adult males already produce enough testosterone to cause near maximal stimulation of the musculature. So that's a very important point. in a healthy person, a healthy young adult male, they are already going to make enough to hit the near maximal stimulation of the musculature. So the increment in muscle mass that could be achieved with exogenous androgens is pretty small. And so people end up taking a whole lot of steroids to get the anabolic effect that they're working for, which is why that becomes so dangerous. Next physiologic effect of the testosterone is that on erythropoietic effects. The testosterone promotes the synthesis of erythropoietin, which is a hormone that acts on the bone marrow to increase production of erythrocytes. So we've heard of erythropoietin before. Sometimes it's a drug that's given to stimulate red blood cell production in anemia or like chronic kidney disease. So we've heard of that before. So you need the action of testosterone together with the high levels of testosterone already present in males explains why men have a higher hematocrit than women. So that's, if you ever want that fun fact of why that is. So next is the clinical pharmacology of testosterone. So again, mainly we're talking about giving prescriptions of testosterone. There are, again, other androgens that potentially could be used. So like endocrinology would know a lot more of some of the other kind of specifics of what they may use. But for the purpose of this course, we're just talking about androgens, which is testosterone. So the primary clinical use of the testosterone is going to be management of androgen deficiency in males. And your principal adverse effect is sterility and hepatotoxicity. Okay. So if you go down to table 52.1 in your book, these will specifically show you the approved uses of testosterone. It says hypogonadism, replacement therapy for men, delayed puberty, or catabolic states, and it kind of goes down through and talks through what these different drugs are that would work. So that's a useful table. The book makes a point to speak on this, that when we're talking of testosterone or testosterone-like compounds, it is traditional to distinguish between androgens and anabolic steroids. But the receptor type that mediates the androgenic effects of the androgens is the same receptor type that mediates the anabolic actions of these hormones. So it's not been possible to separate anabolic activity from just pure androgenic activity. So what they're saying is virtually all anabolic hormones are also androgenic. So rather than creating two categories called androgens versus anabolic steroids and assigning some agents to one category and some to the other, they are referring to them all together for the purpose of the text moving forward. In 2018, the FDA required a label change for all of the testosterone on the market. The new labeling was meant to approve testosterone use only for those patients with confirmed testosterone deficiency due to hypogonadism. The FDA further emphasized that lowered testosterone due to aging does not meet the criteria for hypogonadism. So they started to get a lot more kind of cracked down on the indications for use for testosterone replacement. The Endocrine Society also in 2018 updated their clinical guidelines, and that's listed in your book as well. So just so we're all on the same page, when we're referring to male hypogonadism, we're referring to a condition in which the testes of the male fail to produce adequate amounts of testosterone. Male hypogonadism can be hereditary, or it can result from other causes that can include pituitary failure, hypothalamic failure, and primary dysfunction of the testes. So if someone says they're on testosterone for hypogonadism, it's essentially saying that the testes, for whatever reason, are failing to produce adequate amounts of testosterone. Also to understand when we're talking about testosterone replacement therapy or androgen replacement therapy is beneficial when the testicular failure occurs in adult males. Some studies demonstrate that the treatment will restore libido, increase ejaculate volume, and will support expression of secondary sex characteristics. But replacement therapy testosterone does not restore fertility. So that's a really important point there. Table 52.2 can be helpful in your book as well because they break down these drugs that we're talking about. Again, I don't ever ask you to memorize doses, but some of the special considerations that go with them, some of them are more hepatotoxic than others, and some of them have more androgenic effects than others. It goes into that table too, and it'll specify for you that there are some that require an office visit every 2 to 4 weeks because the blood levels may fluctuate widely, and kind of goes through and gives you some of the specifics. So that table 52.2 could be helpful just to review when you're preparing for questions about male health. We also can have a clinical indication for use in delayed puberty. So in some boys, puberty fails to occur at the usual age, which is typically before the age of 15. Most often, to have that failure will mean that there's a familial pattern of delayed puberty and does not necessarily indicate a pathology. Puberty can be expected to occur spontaneously, but maybe later than usual. So treatment is not absolutely necessary, but some providers will prescribe a limited course of androgen therapy as an off-label idea if the psychological pressures are causing the child significant distress. So in other words, if he's 15, if he's 16, and he just hasn't started puberty, some people will use it off-label to see if they can trigger the start of puberty to help the quality of life for the boy. If delayed puberty is truly related to true hypogonadism, then they would probably be on a long-term therapy replacement plan, and that would be something that would be managed by endocrinology. There is a small place for use of testosterone therapy in menopausal women. We do think that testosterone will alleviate some of the menopausal symptoms, especially fatigue, libido, or genital sensitivity. That makes sense if you think of testosterone as being similar to like an anabolic steroid, right? Like that would help with maybe fatigue or libido. The North American Menopause Society has a statement that says that testosterone can have a positive effect on sexual function, and that women with no other identifiable causes of decreased desire could be a candidate for testosterone therapy, provided that they're also taking estrogen. But in the United States, technically testosterone is not approved for replacement, but it is used in other countries. And some people will use it off-label, and it is a lot lower dose for women than it would be for men. Some people will use testosterone for treatment of cachexia. By definition, cachexia is a wasting of the body associated with severe illnesses. So think of AIDS, trauma, chronic systemic infections, or chronic cancers. The testosterone levels will often decline in those patients, which will put them at risk for wasting and loss of muscle. So there is FDA approval to use testosterone to help decrease the risk of muscle wasting. The drug is oxandrolone, and it's FDA approved, and it's the only anabolic steroid that is a synthetic derivative of testosterone. However, oxandrolone does have a black box warning because it can cause hepatitis, peliosis hepatitis specifically, which is a condition in which the blood-filled cysts form in the liver, which will lead ultimately to liver failure or intra-abdominal hemorrhage, which is also life-threatening. And it can also contribute to the development of highly vascular liver tumors. So also the black box warning talks about an increased risk for atherosclerosis secondary to marked elevations in the LDL and decrease in your HDL because of the drug. But you may see people on it. But again, to me, that's something that's likely going to be managed more by an HIV specialist or an endocrinologist. There have been use also of androgens or testosterones to be used for anemia because we know that they have that erythropoietic effect. Anemias most likely respond to that treatment with androgens would be things like aplastic anemia, Fanconi anemia, or sometimes cancer chemotherapy associated anemia. So these are very specific situations. This is not something that you would be like in the hospital and you have an anemic patient, chronically anemic from whatever the case may be. We don't use androgens in those things. These would be very specific situations and probably managed more, again, by a hematologist than a general practitioner. And then, of course, there's testosterone as drug therapy for transgender men. So what are the adverse effects? Like your slide here says, virilization and hepatotoxicity. But the virilization is the most common complication of testosterone therapy. So when testosterone is taken in high doses by women, the androgen or the testosterone will cause acne, will cause the deepening of the voice, proliferation of facial and body hair. It will lead to male pattern baldness, increased libido, clitoral enlargement, and menstrual irregularities. And the important thing is that clitoral growth, hair loss, and lowering of the voice oftentimes is irreversible. Masculinization can also occur if taken by children. So for an example, if someone very young started taking it for sports performance enhancement, you are going to start to see the sexual characteristics develop much faster. To prevent irreversible masculinization, androgens must be discontinued when virilizing effects first appear. Then the next one is the hepatotoxicity. So androgen, pharmacologic exogenous androgen can cause cholestatic hepatitis and other disorders of the liver, and some people can have clinical jaundice, although it's rare. Patients that do receive testosterone should undergo periodic tests of liver function. And obviously, if they develop increased liver function or jaundice, you would discontinue the use of the androgens. The other issue is that if they're used in a more prolonged fashion, androgens/testosterone can also be carcinogenic, specifically can lead to an increase in the risk of hepatocellular carcinoma. So that's something that has to be carefully weighed as a risk versus benefit. Not all of the androgens are hepatotoxic, and liver damage is primarily associated with the 17 alpha alkylated androgens, which is in that table 52.2. It's the way that those androgens are structurally made, and they do have the capacity to cause the liver damage. So the 17 alpha alkylated compounds should not be used long term. But the 17 alpha alkylated androgens, which are testosterone and the testosterone esters, are not associated with liver disease. So that would be a very specific difference between which group of medications you would use pharmacologically. If you need something more long-term, you're not going to use the 17 alpha alkylated compounds. Other potential adverse effects of exogenous androgens could be the effect on cholesterol. So they could lower your levels of HDL, which is our good cholesterol, and could elevate the plasma levels of your LDL, thereby, if being on exogenous, testosterone has the risk for an increased risk of atherosclerosis or cardiovascular events. Androgens or testosterone replacement does not cause prostate cancer, but they will likely promote the growth of the cancer if it does occur. So androgens are contraindicated for men with prostate cancer. The other thing that can happen with exogenous testosterone or androgens will be edema. That results from androgen-induced retention of salt in water. And that is a big deal if patients already have existing heart failure. Some people may need to be on a diuretic, but oftentimes if they begin to get the edema, they have to discontinue treatment. The risk for thromboembolic events is something that's worth talking about again. There are post-marketing reports. Those reports include thromboembolic events such as stroke, an MI, a DVT, or PE, and they do think that that could be contributed to testosterone's erythropoietic effects. So they do have risk associated with taking them, which needs to be part of your risk-benefit discussion if you're prescribing. Okay, so let's go into the different types of the medications that we can use. That was the slide specifically to let you know which ones are esters or testosterone and which ones are the alpha alkylated androgens. Abuse by athletes. The risk associated with that is listed here. I'm sorry, I must have skipped right past that. The big problem is that athletes tend typically to be young adult men or high school aged men. And so when you're taking the excessive exogenous androgens, such as an anabolic steroid or the testosterone, you can have suppression of your LH and FSH altogether and actually cause testicular shrinkage, sterility, gynecomastia are the big ones. And again, if they're abusing once, certain drugs can have the hepatotoxicity, they can cause renal damage, and then you likely will see the psychological effect of aggressiveness and changes in their personality. All right, let's jump into the different medication classes here. So the first ones we talk about are the oral medications for testosterones. So androgen replacement therapy really has taken off since the 2000s. In the past, your really choice was only intramuscular therapy with a long-acting testosterone ester, but today there's a lot more options available to us. So we have oral medications. Those are two of those that are used only for male hypogonadism. They do have an advantage because of cost and ease of administration, but they are not first-line agents because, and make sure we understand this part, the androgenic effects of the oral androgens are erratic, meaning they're really hard to predict whether or not they're going to work for people. Maybe a small dose causes a huge effect, maybe huge doses hardly work at all. And so they're actually not first-line treatments, even though they're cost-effective and they're obviously easy to take. And some of the ones are 17-alpha alkylated ones that could pose the risk for hepatotoxicity, so they're not used long-term anyway. So there are oral options out there, but they cause erratic effects, so they're not first line for treatment. Next one is going to be our transdermal formulations. And these are pretty popular with patients because they're pretty easy to use. It can be a patch, a gel, or a liquid. And obviously the testosterone is absorbed through the skin and then slowly absorbed into the blood. All right, so specifically patches, they're indicated for male hypogonadism, and there's a couple different strengths. The patches are applied once daily to upper arm, thigh, back, or abdomen. You could possibly have a site or a reaction to the site, like itching, those kind of things, but they're pretty well tolerated. And then the next one would be the gels or topical solutions. So we have a couple different options for those that come in different doses. Compared with the transdermal patches, these are things to know. Compared with transdermal patches, there's 3 advantages to the gels. They cause less local irritation, they don't fall off, and they're actually produce a more consistent and steady level of your testosterone. So in that sense, to me, the gel is likely of a greater advantage than the patches. The principal disadvantage, though, of the gels is that testosterone can be transferred to others by skin-to-skin contact. Okay, doesn't necessarily seem like a thing, but what I'm saying to you is that if you placed the gel, like let's say on your upper abdomen or your thigh, even 12 hours later, if you're hugging somebody or whatever, you could transfer testosterone to that other person and have skin-to-skin contact. That's possible because only 10% of the applied dose is absorbed and the other 90% remains on the skin after the gel dries. So in one study, the blood levels of testosterone were actually doubled in female partners of gel users after 15 minutes of intimate contact that occurred within 2 to 12 hours. So they've actually looked at that, and that's a bad thing, right? I don't think many female partners are going to be happy to have all of a sudden a sharp rise in their testosterone. And that's also worrisome because the drug can cause sterilization of women and could cause fetal harm. So obviously, if you are going to place somebody on a gel formulation, they have to have significant education, so much so that it actually carries a black box warning because you can have secondary exposure, and even exposure on unwashed clothing has caused virilization in children as well. So we don't want that, okay? So the gel solutions work great. They don't cause site irritation. They give a nice steady level of the drug, but you really have to pay attention and know that you have testosterone hanging out on your skin if you're going to use them, okay? So they actually give some guidelines if you're going to be on gel formulations. 1, the gel users obviously need to wash their hands with soap and water after application. They should cover the application site with clothing once the gel has dried. Gel users should wash the application site before skin-to-skin contact with another person. Women and children should avoid skin-to-skin contact with gel users, and women and children who make accidental contact should wash the skin immediately. Also, you would educate your patient if they're on the gel or topical solutions that they should wait 5 to 6 hours before showering or swimming. So there's a couple of things that go along with that. in using those formulations. You also have to monitor the blood levels periodically, usually once at 14 days and then periodically thereafter. Each of the individual drugs have some specifics to them, but in general, we're talking about them as a gel, what we have to know. The topical solutions are for underarm application, is much like testosterone gels. The liquid is formally and specifically formulated for the application to the axilla. And after application, the testosterone is absorbed rapidly into the skin and then slowly into the blood, and you get a steady state within 14 days. But after an application, the blood levels take 7 to 10 days to begin to decline. Patients should not swim or bathe for 2 hours after they put that on. If underarm deodorant and antiperspirant is used, it should be applied before applying the testosterone. Because of its alcohol content, it is considered flammable, this drug. So you should stay away from flames until the solution has dried. You should also really put it on each day at the same time. And again, it is a topical formulation and it can be transferred skin to skin. The next one that we talk about is the nasal gels, and that's the newest formulation, and it has administered nasally, obviously, so it's not a good choice for people who have chronic sinusitis or deviated septum or any kind of nasal disorders. There's a couple of them that are on the market. Anything given in the nose can cause a local reaction in the nose, so you can get a runny nose, a bloody nose, or irritated nose or nose infections because of it. So they also have their own specific administration or patient directions associated with them. The pump should be primed before use and excess gel should be removed. The patient should blow his nose before administration. The pump is inserted into the nostril with a tip aimed towards the lateral nostril wall. You depress it slowly until it stops. When it's withdrawn, it should be wiped against the lateral nostril wall to ensure that the most of the gel is distributed. After administering it in both nostrils, the nose should be lightly massaged below the nasal bridge, and the patient should avoid blowing or sniffing for at least 1 hour. All right, next one is the implanted versions. So these are testosterone pellets that are long-acting formulations that are really useful in male hypogonadism and delayed puberty. The pellets are implanted subdermally in the hip area or your abdominal wall, kind of lateral to the umbilicus. Each of the individual pellets has a certain amount of testosterone. And then every 3 to 6 months, you have to have that removed or changed. So about a third of the dose is absorbed in the first month, a fourth in the second, and 1/6 in the third month. We also have buccal tablets that can be done and taken. They actually do produce a very steady blood level of testosterone. So the tablets are applied to the gum area just above your incisor tooth and are supposed to stay in place until removed. They should be held in place for about 30 seconds. People are supposed to take 1 tablet every 12 hours, alternating the side of the mouth with each dose. And then typically the tablet should stay in there, and if it falls out before 8 hours, you would need to put a new one in. You can still eat, drink, and use chewing gum and brush your teeth, which is interesting to me. It can cause some oral discoloration or irritation or bitterness. And then, of course, we still have our options for intramuscular testosterone esters. Once they're given through an intramuscular injection, the drugs are slowly absorbed and then hydrolyzed to release free testosterone. But the trouble with that is that your actual testosterone blood levels can be varied quite a bit. And sometimes the testosterone levels are higher than normal immediately, and sometimes not. So it's kind of hard to judge how people are going to tolerate them, and some people don't get the effects that they're looking for off of that. At the end of the chapter, again, I would look at the summary of the key prescribing considerations, because it does give us some nice ideas here. You wouldn't want baseline data for your patient. You would obviously need to know what their testosterone is, what their blood counts are, what their lipids are, liver function, and then again the PSA, because as we talked about, there's the worry that if you were to give a androgen to someone with an elevated PSA that's concerning for cancer, we would do more harm than good. And then how you would monitor it, high-risk patients, and then how to evaluate for therapeutic effects. And remembering again that the 17-alpha alkylated androgens can cause the hepatotoxicity and an increased risk for hepatocellular cancer as well. At the end of the chapter, it also goes through drug therapy for transgender men. That gives a couple of points of there, but it's pretty much everything that we've already covered. So I'm going to jump right into the next chapter here on one video just to save the amount of videos we're uploading. So moving on, next is chapter 53. To take a break from listening, this would be a good point to do it. We're going to jump over now into chapter 53, which is the drugs for erectile dysfunction and BPH, building off of then the use of testosterone and also covering these medications. So essentially, to review, the drugs for erectile dysfunction means that we have to understand the pathophysiology and the normal physiology to understand then how we would treat it if something goes wrong. Erectile dysfunction is commonly referred to as ED, and it's a common concern for middle-aged and older men. Once it was considered an inevitable consequence of aging, but now ED can now be managed effectively by medications and other treatments even into advanced age. BPH is even more common than ED, and we've had a lot more development in the last few decades that have really markedly improved our treatment of BPH. So the first kind of idea is to talk about male sexual dysfunction as a whole, because ED would fall under that to begin with. ED is also known as impotence, but that's not the word that we use anymore. It's referred to as erectile dysfunction, or ED. It's the persistent inability to achieve or sustain an erection suitable for sexual intercourse. That's by definition. In the United States, about 30 million men are estimated to have ED, and it's commonly also associated with chronic illnesses like diabetes, hypertension, and then also into depression. For men with diabetes, the incidence of ED is between 35 and 75%, and in 1/4 of the cases overall, it's related to medications. Table 53.3 does give us a great quick table that shows us common drugs that can be used, or drugs that are commonly used that can cause erectile dysfunction. And if you look at these are not crazy drugs, all right? Hydrochlorothiazide, spironolactone, Prozac, amitriptyline, and then Proscar alcohol use, or lithium, or chlorpromazine, some of those. So these are drugs that people could be on, and it's something to consider. If your patient did present with ED, one of the first things you should look at then is their medications, and are there any medications that we could consider stopping and then seeing if the ED were to improve. The risk for erectile dysfunction does increase with age, though. So approximately 4% of men in their 50s will have it, but by 60s, it's about 17% of men. And then the total inability to achieve an erection affects 47% of men over the age of 75. But again, there are medications now that are treating this fairly well, so they don't necessarily have to have it. Oftentimes there's a treatment available to them. The first line treatments for ED are always going to be, just like anything else, oftentimes is lifestyle changes, right? So increasing your exercise, stopping smoking, doing things to promote a healthier mood, and then again also can be just changing some of their chronic medications around that could increase their risk for erectile dysfunction. There's also options for psychotherapy, and then there are surgical options for implantation of penile prosthetics as well. So let's talk about first the physiology of an erection. So this is figure 53.1 in your book, and I think it does a really nice job of helping create kind of this algorithm or step-by-step approach to understand all of the things that are needed to happen in the certain order to achieve an erection. And there's a lot that go into it. And so there's a lot of places where things could also go wrong, but this also will help you understand when we give the drugs to help with ED, then it's kind of like, well, where are they working in this flow? And you can see it a lot better with this. So I do think this is a pretty good. So first of all, the process begins with sexual arousal, and it increases our parasympathetic nerve traffic to the penis, and that causes local release of the nitric oxide. So that's our part here, okay? The nitric oxide then activates guanylyl cyclase, which is an enzyme that makes our cGMP. So activation of this guanylyl cyclase, which makes GTP as well, but we're really focused on this one, which is cyclic guanosine monophosphate, so our cGMP. And then through another series of steps, this cGMP will promote relaxation of the arterial and trabecular smooth muscles. So that's here in the two different ways here. That causes arterial dilation, which increases the local blood flow and the blood pressure, which in combination with the relaxation of the trabecular smooth muscle can cause expansion and engorgement of the sinusoidal spaces in the corpus cavernosum, right? That in turn then causes venous occlusion and reduces venous outflow, which is going to cause engorgement of the blood and the blood volume. So you see this intracavernosal volume and pressure increase, and you get increased penis size and rigidity. And therefore, that would be what is considered an erection. Erection then subsides when the cGMP is removed by the phosphodiesterase type 5, which is the PD5, which is an enzyme that converts the cGMP to the GMP. So removal of the cGMP by the PDE5 restores the penile smooth muscle to the non-aroused state, and detumescence ensues. And the vasculature opens back up, the engorgement can outflow, and the erection is gone. That's an important component to understand, because the medications that we give can be our PDE5 inhibitors, and then other medications that act here on the relaxation of the arterial smooth muscle. So when we talk about the medications then, the main one is the phosphodiesterase 5 inhibitors. Oops, okay, fix my screen here. And remember that the PDE5 inhibitors are the most commonly used drugs, and those are the ones that are the oral agents to take. Okay, so that's really the primary focus of erectile dysfunction, is the use of the PDE5 inhibitors. The drugs are summarized in your table 53.2. I do like that it talks about the considerations there of things you would need to know for each specific drug. So let's go through some of these ones and talk about it. All the drugs, there's 4 choices, are considered to be first-line treatment for ED, but all men with ED all of the drugs for ED do have some nuances to them that maybe would be more specific for one to the other. There's not a lot of trials that have compared these against each other necessarily, so it's really provider preference or patient preference. The first drug was produced in 1998, and that's the Viagra, which is sildenafil. And that was the first drug we had. It's reliable and it's really easy to use. So it works by enhancing the natural response to the sexual stimuli. So it's important to remember that sildenafil does not cause the erection directly, but it does enhance the natural response to a normal sexual stimuli. So that's important to understand, because in general, just by taking the Viagra should not result in an erection. You have to have a sexual stimuli and get that process started, and then it works as the 5-DE inhibitor. It's generally well tolerated, but the big thing you're always going to remember with these drugs is that men taking certain vasodilators, specifically any alpha adrenergic blockers, specifically nitro or other nitrates, can have a really bad outcome if they take the 5-DE inhibitors related to severe drop in the low blood pressure. Okay. So the erection enhancing effects that you will see from sildenafil were actually discovered by accident. They actually developed the drug as a cardiac medicine, but that really didn't work well. But they noticed that this was a side effect men were talking about, and so then they studied it in that way. There is, again, a use for sildenafil outside of ED, and that is approved for pulmonary arterial hypertension, and that's the trade name of that is sold as Revatio. So there is a use of it outside of erectile dysfunction. Okay, mechanism of action. It works because it is selectively inhibiting the PDE5 stage. So by doing that, it increases and preserves our CGMP levels, thereby making the erection harder and be able to last longer, because essentially you're shutting off this part here and not letting this resolve. It should consist and persist for quite a while. In the absence of sexual stimuli, however, nothing is going to happen. Education for patients is for all of the PDE5 inhibitors here as well. We'll talk about that here in a minute. So the benefit of taking the medication is to help with men with erectile dysfunction. And it's also important to note that the ED can be from a variety of causes, both organic, psychogenic, or even vascular, whatever the case may be. If it's related to diabetes, for example, this drug still should help. At least some improvement in erectile hardness and duration was seen in over 70% of the men taking the drug. The benefits were dose-related and only lasted up to 4 hours, although they do begin to fade after 2 hours. So it is instructed that patients take the dose 1 hour before sexual activity. And so that can be kind of a quote unquote mood killer. I've heard patients say it reduces the spontaneity of intimacy with their partner. And so that could be a downfall for people, but it does tend to work well. And so that's just something that they have to take into consideration. It is what it is. In men without an erectile dysfunction, there's not really been shown to have any effect on the quality or duration of an erection. So it's really funny to me that people will talk about like taking a Viagra party in college or those things. And really, it's probably not doing a whole lot of anything for people. And it does have the potential to have bad side effects, right? So it's really a stupid thing to abuse, in my opinion. However, that's the case. Remember that you could have a woman on sildenafil because she could be on it for pulmonary artery hypertension. But if women try to take it in terms of increasing their sexual experiences or something, they failed to show any enhancement of sexual arousal or have any benefit of women and related to that. There are the differences between PDE5 inhibitor 1, and then there's the second class that have come later after the sildenafil did. And those are vardenafil, tadalafil, which is Cialis, and avanafil. The benefit of some of these other drugs is that they work a little different. So those drugs specifically work at relaxing the arterial and trabecular smooth muscle within the penis. So they work a little different than the sildenafil. So if sildenafil didn't work for a patient, it would be worthy to try the second class of drugs. Some people like Cialis because the effects can last up to 36 hours, and you can dose it as needed as well. But some people take it daily if activity is anticipated twice weekly. But for some men, that is a big draw to the Cialis or the tadalafil instead of sildenafil, because you don't have to take it 1 hour prior to sexual activity. And the same thing for Avanafil. You still have to take that pretty close to sexual activity. So there's a lot to be said. The two main classes that I see in practice the most are going to be, or classes, the drugs are sildenafil or tadalafil. Those are pretty much the two that I've seen in the last 15 years of use. I've not come across those other two, Levitra or Stendra, but they're out there. Obviously, that we should know about. Okay, so when we talk about any of the PDE5 inhibitors, whether it's the sildenafil or like tadalafil, we have to have good patient education. The drug can be taken with or without food, but a high-fat meal will delay the absorption of Viagra, but not tadalafil. Grapefruit juice should be avoided because it can raise the PDE5 inhibitor levels. We very, very, very much have to have a good history and physical for patients before you would prescribe a PDE5 inhibitor, because anybody with pre-existing cardiovascular disease needs to have a discussion. There is a cardiac risk during sexual activity, irrespective of a PDE5 inhibitor or not, but it's certainly something that you would talk about. You would advise men who experience any symptoms that are a concern: chest pain, short-headed or lightheadedness, feeling short of breath, chest pressure, those things during sex. They should refrain from using the drug or any sexual activity until they talk with their prescriber. The other big thing is the risk of priapism, which is an erection that lasts more than 4 hours. So if they've had that for 4 hours, they need to go to an emergency room. All of the patients using any of these drugs should seek immediate medical attention if they develop sudden loss of vision in one or both eyes, or if sudden hearing changes occur. And then if patients are on these drugs, then they have to worry about if they're on nitrates. So for an example is you can't take a nitrate for at least 24 hours after taking sildenafil, or at least 48 hours after taking tadalafil, because it's an extended release drug. And so that's of concern if people have nitrates for medication for blood pressure or as needed for angina or whatever. The next thing to know, so we had patient education, sorry for you taking notes, here and here. So the first thing is the patient education, right? The next thing to know is the potential adverse effects for what you're going to discuss with your patients. At recommended doses, sildenafil produces a small reduction in blood pressure, about 8 points, 8 millimeters of mercury. But in men who have taken a nitrate or an alpha blocker, we're talking severe potential for hypotension to the point of possibly cardiac collapse. So you really, that's a test question, a board question, a certification exam question that you're going to get, is something about a PDE5 inhibitor and the risk of cardiovascular disease or the risk of being on nitrates. It's one of those big things you just have to know. Then again, it's the priapism. So if an erection has lasted more than 4 hours, they need to go seek immediate medical attention, because if left untreated, that can cause permanent damage of your penile tissue. And if it lasts longer than 24 hours, chances are very high that the patient will never have sexual intercourse again. So even if it's an embarrassment, even if they're just, oh my gosh, I can't believe this is happening, they have to go get it treated. The way that is treated is that they would aspirate blood from the corpus cavernosum, followed by irrigation with a solution containing a vasoconstrictor, such as epinephrine. And then if that doesn't work, surgery is required to actually go in and unengorge the erection and make sure that it resolves. So it's a serious risk that people have to understand. The next one is that vision change. So non-arteritic ischemic optic neuropathy is very rare, but it has happened. So it's referred to as NAION. So men taking sildenafil have developed this, resulting in irreversible blurring or loss of vision. The cause is blockage of blood flow to the optic nerve, it would mean that you never take the drug again. And again, it's a problem because it could be irreversible. And so if it only happened in one eye, you could possibly lose your vision in the other eye. The next thing is the sudden hearing loss. So very, very rare, but it has been known to happen. It's been documented that men taking sildenafil have experienced sudden hearing loss, sometimes in one ear only, associated with like tinnitus, vertigo, or dizziness. It can be partial or it can be complete, and in a third of the cases, the hearing will return by the time the loss was reported, but in 2/3 of people, it does not return. So if they have sudden hearing loss, they should discontinue the drug and go talk to their doctor. Okay, the common ones are people can have a headache, flushing, or a little bit of GI upset. Sildenafil specifically can also cause nasal congestion, diarrhea, rash, or dizziness. About 3% of the patients will experience a mild but transient visual disturbance. Some say a blue tinge to their vision. Some have light sensitivity. Some will have a brief period of blurring of their vision. Not considered anything that would prevent them from taking it again. Sildenafil may intensify symptoms of obstructive sleep apnea, possibly by relaxing the pharyngeal muscles or dilating the pulmonary blood vessels. So certainly if someone has obstructive sleep apnea and they're going to be on the sildenafil, they need to make sure after taking it and using the drug, they need to be wearing their BiPAP or CPAP or whatever they're on. All right, drug-to-drug interactions then are obviously something I've already talked about, which is the nitrates. So those are both short-acting and long-acting. And if these drugs are combined, life-threatening hypotension can result. So sildenafil is absolutely contraindicated for men taking nitrates. That's really, 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 really important to remember. You're going to see that again in your career that you need to know that information. Okay, the next drug we have to talk about is the alpha blockers. So typical ones you may see are doxazosin, which is Cardura, or other alpha blockers used for prostatic hyperplasia, which we'll talk about in a minute. But those meds are alpha adrenergic antagonists, so they are dilating the arterioles and can thereby lower blood pressure. And so they can cause mainly also postural hypertension. So they can be used, but caution with a lot of patient education, and oftentimes the patients can't tolerate it, in my experience, and it's not a good choice. They could interfere with other inhibitors of the CYP3A4, so ketoconazole, erythromycin, and grapefruit juice are the big ones, so use with caution. The big thing then is that these drugs are typically going to be indicated to use in older gentlemen that are having higher risk for erectile dysfunction, right? So 65-year-olds, 75-year-olds. Well, obviously that is likely also going to be a group of men that maybe already have diabetes, for example, but definitely fall into a category of being concerned that they either already have underlying heart disease or cardiovascular disease, or they certainly have risk factors for it. So when sildenafil kind of took off, and then we kind of started having some of these post-marketing reports come in, a lot of studies and looking at the drug and related to cardiovascular disease occurred. So there were, the book goes into this and says there were two big observations through the studies and the research that was done. First, giving sildenafil to resting men with severe coronary heart disease produced no harmful effects on coronary blood flow or any other hemodynamic parameter. And secondly, in men with stable heart disease who were performing exercise, sildenafil had no effect on symptoms, and it did not cause exercise-induced ischemia. So by the reports that they observed through their studies and observational studies, they are saying that the results suggest that men with cardiac heart disease and men who have sexual activity and not taking sildenafil is likely the cause of the ischemic event. So they kind of came out with, long story short, you can use it with caution. So according, the drug should be used in caution by men with the following conditions: an MI, a stroke, or a life-threatening dysrhythmia within the last 6 months. If they have a resting blood pressure that's less than 90/50, or if they have a resting high blood pressure of 170/110. If they have heart failure or if they have a history of unstable angina, they likely shouldn't really be taking sildenafil. And then they should not be taking it at all if they take any nitroglycerin or a drug of the nitrate family. To be the safest, candidates for sildenafil therapy should undergo a careful evaluation of cardiovascular function. Those with impaired function should be counseled about the risks and all other moderate to intense physical activity. Other thing to remember is that one of the alpha blockers that we do use often also for men is tamsulosin, which is Flomax. But Flomax can be safely used with tadalafil. So that is a good thing to know because a lot of men are on Flomax as well. So that is safe with the tadalafil. And then quickly to talk about, we do have some of the non-oral drugs used for erectile dysfunction. And those drugs are alprostadil and papaverine phentolamine. And those are administered non-oral route. They're given injection into the penis or by insertion into the urethra. And obviously those are considered inconvenient methods of dosing, so they're second line. The alprostadil active ingredient has the same chemical structure as prostaglandin E1, which has vasodilating properties, so it will help with the relaxation of the smooth muscle, causing rapid inflow of the arterial blood. Then the transurethral pellets is the only ED drug that is approved for twice daily use. It's inserted into the urethra. You load a pellet into a small plastic applicator, and then that's inserted about 1.5 inches into the urethra. And an erection will typically develop 5 to 10 minutes and last 30 to 60 minutes. And then there's the intracavernous actual into the penis itself as a direct injection. The response is rapid, and apparently the injections are relatively painless. But it does not last for more than 1 hour, and it should not be used more than 3 times a week or more than once in 24 hours. If you have ongoing use of the injections, penile fibrosis can occur. Then there's the papaverine plus phentolamine, and then we don't really see those in practice, so I'm not going to ask you any questions about that on the test. Then we have some of the other interventions for surgery or devices. So we have a vacuum-assisted device which will promote an erection by increasing the arterial blood flow to the penis, and the erections are maintained by applying a constrictive ring at the base of the penis to sustain the engorgement. The penile prosthetic comes in 2 basic types, a rod, which results in a permanent erection, or an inflatable prosthetic that are inflated by the use of a pump placed within the scrotum. So penile revascularization is less frequently used because good outcomes are low compared with other options. And then again, there are some people that have psychotherapy as their way to manage their erectile dysfunction. Then we do have clinical guidelines for the management of erectile dysfunction that are listed here, and kind of walk you through, which is a great tool to have maybe for like test questions or just to look through again and really understand the process for that. All right, we're moving on. There is, since we're also talking about male sexual dysfunction, there is a section here that I do just want to touch on because it is something you can come into with men that they may bring to you for practice questions. You know, in practice, you can see this, is the premature ejaculation. And that's considered by many to be the most common type of male sexual dysfunction, but it really depends on how you define it. The definition used most by lay people is simply that ejaculation occurs earlier than a man or his partner wanted to occur. The definition was not sufficiently restrictive for research purposes, though, so the International Society of Sexual Medicine created criteria for premature ejaculation. Ejaculation occurs before or within 1 minute of vaginal penetration from the first sexual experience, or within 2 to 3 minutes if it's acquired. So if your first sexual experience versus whether or not it's been acquired later in life. An inability to delay ejaculation in all or almost all vaginal penetrations, and psychological distress due to inability to delay ejaculation. So using those criteria, they think about 4% of the male population would suffer from this disorder. There's no real true understanding necessarily of why it happens. They think it's genetic or hypersensitivity of the glands, penis, or just overexcitement. But it can have significant psychological factors, such as performance anxiety, body image concern, and then interpersonal relationship issues. They're also looking into whether or not there's a role of the neurotransmitter dysregulation. So there's a lot of research actually that's still going on in that as well. So drugs for that is really none. It's behavior modification, psychotherapy, or combination. No drugs has actually received FDA approval for treatment of that, so the drugs would all be off-label. Some of them are considered to be the SSRIs. Remember that when we've talked about SSRIs, one of the possible adverse effects is that the serotonin causes a delay in ejaculation. So they're thinking that SSRIs prevent reuptake of serotonin, thereby increasing the amount of serotonin in your neuronal synapses. And so they think that that's kind of what could help or work as well. When you do use them, paroxetine appears to be the most effective, and it's typically given in a lower dose. There are some use for topical anesthetics for that as well. And then there are some people that use the off-label drugs also of tramadol or a TCA. There has been some success with radiofrequency ablation to kind of burn one of the nerves to disrupt the signal. But really, that's probably something that I would transfer out to a specialist to help deal with if I had a patient present that concern to me. All right, so the next section, we've moved past male sexual disorders, and we're going to go into BPH. BPH is extremely common. It develops more in more than 50% of men by age 60, and by age 85, 90% of men are going to have BPH. Although BPH and prostate cancers can coexist, there's no evidence that one predisposes one to the other. Okay, so let's review the pathophysiology of the prostate so we can understand when you have the hyperplasia and how we could treat that. The prostate is a heart-shaped gland that surrounds the male urethra. Just grabbing an image off the web here to show you so we can really see what we're talking about. Here in the middle, this gray, this is your prostate for men. And this is obviously the penis, and then we have the urethra. So as you can see, the urethra comes up and goes through the center of the prostate. The prostate kind of forms around the urethra, and that then goes into the bladder. Also right here is the seminal vesicles where semen is produced that also comes in to the prostate area and then enters into the urethra, and then sperm would be ejaculated this way. So there's a lot of structures here at play. We have the testes down here that are producing the sperm into here to the vesicles and then through ejaculation here. The bladder is very near to us here, but also we have a lot of neurovascular bundles that sit in here that feed into this area as well. It's very vascular and with a lot of nerves. Also right here you can see in the back, this is the bottom of the coccyx. So sometimes pain in here can radiate back into these nerve bundles up into the back. Also right here is going to be sitting our rectum. So that is why when you're going to have a prostate exam, a finger is inserted through the rectum and you could feel through the wall, the outside of the prostate there. So I do think this is just a helpful review to kind of see what we're talking about structures. I don't know that people always have understood that the urethra actually goes through the prostate tissue. It's not on top of it. It's not next to it. It runs through the tissue itself. In healthy men, the prostate's about the size of a walnut and only weighs between 4 and 20 grams. But when you get into BPH, it can be quite enlarged and can reach up to 50 to 80 grams. So that's can be 10 times the size it's supposed to be. BPH is a non-malignant prostate enlargement that's caused by excessive growth of the epithelial or the glandular cells of the smooth muscles. The overgrowth of the epithelial cells causes mechanical obstruction of the urethra, right? Which makes sense. If you're having overgrowth of the cells that can actually compress down, so not just growing outward, if it grows overall, the two parts that surround the urethra are going to continue to grow and they can actually press in on the urethra and cause mechanical obstruction, a physical blockage of the urine being able to leave the bladder. But if you have overgrowth of the smooth muscle, that can cause dynamic obstruction of the urethra. In men with BPH, the ratio of epithelium to smooth muscles can vary greatly. It's 1 to 3, 4 to 1 in general. The larger the prostate, the higher the percentage of the epithelium being an issue as well, which can lead to mechanical obstruction. So if you see somebody who has a significantly enlarged prostate on a CT scan, for example, when we're getting to those very large sizes, they're likely going to be having some kind of retention or an actual obstructive kind of component to that. All right, the signs and symptoms of the BPH would be hesitancy, urgency, frequency, dysuria, nocturia, straining to start or straining to stop, post-void dribbling, or decreased in the caliber or the stream, and a sensation of I didn't empty completely. There is no direct correlation between size and symptoms. So people can have a moderately enlarged prostate on an exam and report 0 symptoms, or you can have an extremely elevated enlarged prostate and have moderate symptoms. There's no correlation. The long-term complications of BPH will be that if eventually we get obstructive nephropathy, you're at increased risk for bladder stones and then increased risk for urinary tract infections. So how do we treat them? There's 3 choices: invasive treatments, drug therapy, or quote-unquote watchful waiting. The invasive options include the TURP, transurethral resection of the prostate, laser prostatectomy, there's transurethral electrovaporization of the prostate, and then transurethral microwave therapy. Those procedures are most appropriate with men with severe symptoms or complications. If they only have moderate symptoms, then we typically will go to the drug route. And then watchful waiting is for people with very minimal symptoms that are just going to have annual evaluations of it. All right, there's 2 major classes of drugs. We have the 5-alpha reductase inhibitors and then the alpha-1 adrenergic antagonists. With either drug, the goal of treatment is to relieve bothersome urinary symptoms and delay disease progression. Okay. The 5-alpha reductase inhibitors are most appropriate for men with very large prostates who tend to have mechanical obstructions, whereas the alpha blockers are preferred for men with relatively small prostates and have more of a dynamic obstruction. Okay. So your table 53.4 gives us a nice table here that breaks them down. So the 5-alpha reductase inhibitors, they work by reducing dihydrotestosterone production, which causes the prostate to shrink. That then reduces mechanical obstruction of the urethra and likely will delay BPH progression, but it takes months to achieve and to see the effects you're looking for. The bad part about it is it could decrease ejaculate volume and could decrease your libido. And these drugs are teratogenic to the male fetus. So pregnant women should not take them. Your alpha blockers can be divided into selective or non-selective. Selective alpha blocker is Ciloticin, which is Rapaflo, or Tamsulosin, which is Flomax. And those drugs are selective, so they block alpha-1A receptors that relax the smooth muscles in the bladder, neck, the prostate capsule, and the prostatic urethra, and thereby decrease dynamic obstruction of the urethra. And those benefits happen quickly, rapidly. However, they can cause abnormal ejaculation and risk of floppy iris syndrome during cataract surgery. Another random fact to know. Okay, so our selective alpha-1 blockers are really effective and they can help relax the smooth muscles and really decrease dynamic obstruction, and that can happen quickly, like within a dose or 2 of taking it. Then we do have the options of the non-selective alpha-1 blockers, which is alfusin. I cannot ever say that. I always call it Uroxetrol. Alfuzosin. There you go, alfuzosin, and then doxazosin or terazosin. They're the same mechanism of action as the selective alpha-1 blockers, but these guys can cause hypotension, and postural hypertension is the big one, also somnolence and some nasal congestion. Okay. The other drug class that we could possibly use is tadalafil, which is Cialis, and that also will help smooth muscle relaxation in the bladder, urethra, and prostate. But again, it has the potential for hypotension or always priapism. but it can be nice sometimes to kill two birds with one stone by using tadalafil to kind of treat both BPH and erectile dysfunction. Then we have a drug called Jalin, which is tamsulosin dutasteride, and that combines the effects of the 5-alpha reductase inhibitor and the selective alpha-1 inhibitors, which is showing a lot of progress as well. For years, though, people have been on both types, but now we finally have a drug that combines them together. The big thing to remember, though, is that your 5-alpha reductase inhibitors are really going to be the best ones for decreasing your mechanical obstructions, but that takes months, and those can be teratogenic to a male fetus. And then your selective versus non-selective both work the same way by reducing the smooth muscle in the bladder, neck, and the prostate capsule and can help with dynamic obstruction. But the difference is that the non-selective alpha-1 blockers have more potential for cardiac side effects like dizziness, somnolence, fainting, or hypotension from like decreased blood pressure. Oop. Going through these drugs a little bit more specifically and highlighting a couple things. One is finasteride. Because the percentage of the epithelial tissue is highest in very large prostates, finasteride is the most effective in men whose prostates are highly enlarged, which we said, but the shrinkage could be expected to happen over a period of 6 to 12 months. Possibility for those adverse effects with the finasteride is that it does not have a lot of symptoms. It's pretty well tolerated. One of the possibilities, though, is the decreased ejaculate volume, decreased libido, and even risk of gynecomastia. Finasteride can protect against prostate cancer because it reduces the levels of the DHT, dihydrotestosterone, but only when the cancers are classified as low grade, and it does not protect against high grade prostate cancer. So when given to a healthy man to prevent prostate cancer, finasteride actually increased the likelihood of a high-grade tumor. So the FDA recommends against allowing the manufacturer to label finasteride as a drug for prostate cancer prevention. So if you may see that, like if they're Googling their drug, there's literature out there and you may be getting those questions of like, oh my gosh, what's going on with my cancer risk? The other thing to remember then is that finasteride is teratogenic to the male fetus, so it cannot be with pregnant women, or pregnant women shouldn't handle it and obviously shouldn't absorb it. Men are also advised not to donate blood if they're taking it until at least 1 month after. A really other important thing that I should add to these slides, but I want you guys to add, is that finasteride decreases the serum levels of your prostate cancer. It's expected to do so. So PSA levels should be determined before treatment and 6 months after. If a PSA is normal at the start of treatment, but the levels actually don't fall, they should be referred to be evaluated for potential prostate cancer. Okay, so it will decrease them and it should decrease the PSA. So never start finasteride until you know what their PSA is, so it can be tracked and monitored. So if you had a normal prostate, or excuse me, a normal PSA, and then you were on finasteride, and then you developed prostate cancer, you would have an increase in your PSA. But because the drug is decreasing it while the cancer should be increasing it, sometimes the levels just don't move. So it's really important that you monitor the PSA before you would begin finasteride or dutasteride. Dutasteride is a little different than the finasteride because it has an extremely long half-life of 5 weeks. So it takes over a month to clear the drug. Dutasteride is pretty well tolerated, but remember it's also teratogenic. It is typically given in a capsule form, but the capsule contents can be irritating to the oropharyngeal mucosa, so it has to be swallowed whole with a glass of water. And then a couple points about the alpha-adrenergic agonists. Remember, the non-specific, non-selective alpha-1 blockers are especially useful for patients with hypertension. But if people have normal blood pressure or they're already on a lot of drugs for hypertension, and then you add on a non-selective, you're really at risk for developing hypotension. Another point to remember is the alpha-adrenergic blockers or antagonists do not reduce your PSA. And then again, men undergoing cataract surgery have to know and tell people that they're taking an alpha-1 adrenergic antagonist. There is a reason that some people may have a use of tamsulosin in women. It's considered off-label for urinary hesitancy or bladder outlet obstruction from like a kidney stone. So sometimes women will be prescribed tamsulosin to help relax the smooth muscles and relax the ureter and the urethra to pass the stone. Let's see. Let's add a new one. Is the anticholinergics. Okay, so symptoms of overactive bladder in men are like those urgency and frequency, and they're very common with BPH. So there is a role for anticholinergic drugs that could be helpful. So darafenicin, oxybutynin, sulfenacin, tolterodine, those drugs may be used alone or in combination with an alpha blocker such as tamsulosin to improve urinary symptoms. So don't forget that. It is a really good point to add that the oxybutynin, for example, or the sulfenacin, which is Vesicare, can really be helpful. And then there's actually a use for other things like Botox. Don't see that very often in my practice, but I know they do use it in urology. And then remember, we did talk about briefly saw palmetto, about being an herbal preparation that can help with that as well. So you may see that in practice. Slides from the book themselves added a couple of review questions, so let's go through these. A patient has been prescribed sildenafil for erectile dysfunction. Which instructions should the nurse include in the teaching plan? Take the medicine on an empty stomach, drink plenty of fluids to prevent priapism, avoid taking nitroglycerin with the drug, or that constipation is common. It is avoid taking nitroglycerin with this drug. A patient is taking finasteride for BPH. The nurse should explain that this medication has what effect? Decreases the size of the prostate gland, relaxes smooth muscles of the prostate gland, reduces the risk of prostate cancer, or improves sexual performance during intercourse. And the answer is A, will help decrease the size of the prostate gland. The nurse should instruct a patient prescribed sildenafil to avoid taking this medication with what? Grapefruit juice. That one was easy. All right, that ends our male health section. Hopefully this is helpful for you guys to review these things on the videos. And as always, please reach out if any questions or concerns.